let's go ahead and move on to Wolff-Parkinson-White syndrome. We discuss individuals that have structural problems with potassium channels. Now let's move on to discuss more macroscopic problems that may occur in the conduction system of the heart. Classically, people with W2PW will have an accessory conduction pathway that directly connects the atrial and ventricular myocytes in a location completely different than the AV node itself. Now, why is this bad? Well, as you can see here, there's this accessory pathway, usually termed the bundle of Kent. It is an accessory bundle of conductive tissue in the lateral parts of the left atria and ventricle. This is bad because the AV node is no longer the one-way traffic stop for the conduction of the impulses to the ventricles. So what can this cause? The accessory pathway conducts electrical impulses much faster than the AV node because the accessory conductive tissue does not have the same slow inward calcium current as the AV node. This accessory pathway uses fast sodium channels. Stimulation of the ventricular myocytes will occur earlier than normal because this accessory pathway conducts much faster than the AV node. So compare it to the AV node, which should be the only conducting pathway between the atria and ventricles. Okay, so we depolarize the ventricular myocytes a little sooner than we want. Is this bad? Yes, we are directly depolarizing the ventricular myocytes instead of spreading the electrical impulse via the Purkinje system. So we bypass the Purkinje system when we use this accessory pathway. This is a real problem because the conductance between myocytes via gap junctions in those ventricles is much slower, and we have set that off by causing depolarization of the ventricular myocytes via the accessory pathway. We've set off this depolarization that is much slower than if the impulse was to be conducted through the AV node and then through the ventricular myocardium via the super fast conducting Purkinje fibers. The spread of the impulse that came via the accessory pathway will be a very slow depolarization when it hits those ventricular myocytes because it relies on gap junctions to spread those depolarizations from myocyte to myocyte. But the real problem is that this depolarization hits those ventricular myocytes much sooner because there's no AV nodal delay. This is responsible for that shortened PR interval and the delta wave that you see. So you see our PR interval is shorter, and the delta wave is this early upstroke of our QRS complex. So the combination of two depolarizations, one traveling via this accessory pathway, and then one traveling via the AV node, which is the normal conduction tract, will actually cause you to have a wide QRS complex. So you have this initiation of depolarization via the accessory tract, which is a delta wave that causes you to have an earlier onset of your upstroke of your QRS complex, and then the conduction via the fast Purkinje fibers eventually will catch up. This spreads out your QRS complex because you're summating two depolarizations. You're summating two electrical vectors. In summary, what you need to know about WPW is that you'll see a shortened PR interval because of the accessory tract depolarizing the myocytes because we completely bypass the AV nodal delay. The depolarization is slow of the ventricular myocytes, so it's a very slow upstroke which causes that very slow slanted slope of our delta wave. We have a wide QRS complex because there are two depolarizations and therefore two mean electrical vectors that we are summating together. The first one is the component of the delta wave due to the accessory pathway, and the slow upstroke because we're using gap junctions in between myocytes for our depolarization. So ions flow from cell to cell, and that's very, very slow compared to the Purkinje system. Another important thing to consider is that the two tissues, this is the bundle of Kent that composes the accessory pathway, and the AV node have different refractory periods, just like they conduct at different velocities. Worst case scenario is that we may encounter a situation in which one of the tracts, let's say the accessory tract, has already depolarized and then repolarized, while the AV node is now just finally sending that impulse through. This sounds like a perfect situation for propagating an impulse in a retrograde or backward fashion from the ventricles back up to the atrium. So if we have this ready to fire again, and this now just sends the depolarization through the Purkinje system, you can actually have a continuous circle through the system, and it can just go round and round and continue to depolarize in that macro circuit. Macro being large and circuit being a connection of electrical conductivity. Essentially, we just created an abnormal anatomical conductance loop or macro circuit. As you can see here, there would just be electrical conductance going around through a circuit that was very dangerous because there will be unsynchronized depolarization of the atria and ventricles, we need that AV nodal delay, and that needs to be the only segment that is conducting from the atria to the ventricles.